This conference will now be recorded.
Assalamu alaikum wa rahmatullahi wa barakatuh. In the name of Allah, we'll start today session for September exam, inshallah. I think it's still one session only for Dr. Rasha. We will post soon. The last one will be for Dr. Rasha. In the start of the session, to all my colleagues, I would like to tell thank you for taking all the challenging and giving a good outcome of it. I appreciate your group effort. You are the best team managers ever. Thank you for being a part of the team. Without your cooperation and dedication towards the course, we could not pull the work together. Your continuous support, encouragement, and guidance have helped me to reach many professional milestones. You are the mentors that every star-eyed new membership needs. My admiration and respect for you only grow each day I spend under your mentorship. Thank you for making our course life easier. It's a great honor to be here amongst all of you. Dr. Osama Aql, Dr. Hani Tahir, Dr. Ali Abul Majd, Dr. Zib Quraish, Dr. Samira Khan, Dr. Ahmed Al-Agami, Dr. Majid Al-Saadawi, Dr. Rasha Hamid, Dr. Ahmed Al-Gharyani, Dr. Ibtihal Al-Murghani, Dr. Fahmi Dakour, Dr. Sidra Ali. Special thanks for the unique coordinator of the crash course, Dr. Asif Ahmed Sufi. I don't have enough words to thank all of you, but really I'm very happy that I am amongst all of you. Today we'll start the sessions, and this is very important sessions for the exam. Herpes simplex and endometrial hyperplasia, because this is could be AMQ. AMQ means three questions. I think the sound clear. Can you post in the chat if the sound clear or no? Sound clear or no? So it's clear. Okay. So we'll start with herpes simplex in the exam in part 2. You could face as 3 AMQ questions. You should understand the question. AMQ depend mainly on your understanding the question. Single best answer, maybe you can only information you know, but in AMQ you should be clever. You read carefully the question. And herpes simplex, you can face 3 AMQ and also endometrial hyperplasia. We'll start first with genital herpes. There is 2 types of the herpes. Type 1, it's a DNA virus. This is type 1 and type 2. Type 1 mainly affects the orolabial, and the type 2 affects the genital area. So genital areas, there could be type 1. Yes, there could be type 1. There could be type 1 also in genital area, about 1/3. 1/3. In the history, if the patient she will have symptomatic partner, this is not essential. Maybe she will tell you, my partner don't have herpes, so she can even take the infection from her partner who is asymptomatic. And the viral shedding can lasting up to 3 weeks after primary infection. After primary infection and recurrence are common. The neonatal herpes is very rare, but if it is happen, it's very serious, because this will lead to high morbidity and mortality. There is 3 subgroups of the infant infections according to the site of the infection. The best prognosis, the best one, if only in the skin or the eye or the mouth. This is the best prognosis, and only this will represent about 30%. So it's 30%, but it's the best prognosis. 70% will be local CNS nervous system and disseminated infection. The highest mortality will be with disseminated infection. The highest neurological morbidity will be with the local CNS. If you can possible, all of you mute yourself so the sound in the record will be clear. Disseminated herpes is more common in the preterm, and exclusively it will be result from primary infection of the mother. دكتورة أسماء possible you can دكتورة أسماء. Time now is very important, so please we don't want to waste time because only few days for the exam. We will start. Who wanted to chair? Who wanted to chair, please, so we can start. No questions allowed in between the...
Can I share?
Dr. Sweta. Okay, Dr. Sweta. What is your name, doctor?
Sumaya.
Dr. what?
Sumaya.
Swaita? Dr. Swaita?
Yeah.
Hello? Okay, so only Dr.
Yes.
Swaita will chair. Please, other your mic, please. No questions, please allow it in between the questions. We can postpone until the end. Okay, you can take the first,
Yes,
the first 10 questions. Just check your internet. I think the voice clear. Okay, you can start.
Herpes, the commonest virus in the
Dr. Sweta, your voice is much interruption. We can take another one until you fix your internet.
commonest herpes virus in the neonate or
Dr. Sweta, I can't hear you. So please, we can take another one until you prepare your internet because I can't hear you. You can take the second 10 questions. Any others can share? Please, someone another one so we don't want to waste time.
Can I try?
Dr. Asma, Dr. Sweta, please mute yourself until you fix the internet. Dr. Asma.
The commonest herpes virus in neonate causes in neonate cause neonatal herpes is herpes simplex virus type 1, type 2, 30% type 1 and 70% type 2, 50%. It is D, 50% type 1 and 50% type 2.
So 50%, 50%. So both virus can affect the neonate equally. So 50-50. So it's easy. Okay, next. Neonatal infection can occur intrauterine, but extremely rare. When the infection will happen? Infection will happen at the time of the birth of the baby. So any postnatal infection can happen. Yes, 25% of the infection to this baby can happen postpartum, postnatal. From where? From kissing, especially if mother or the relatives they have oral herpetic lesion and they kiss this baby. He can get the infection from them, and this will be a deadly kiss because this will increase the morbidity and mortality for this baby. So mostly with the birth, rarely intrauterine. It can happen natal, 25% from kissing from one with infection in the oral. Next.
The risk of perinatal transmission depends on the timing of maternal acquisition of HSV, with the highest risk of infant born to women who have primary herpes will be in first trimester, second trimester, third trimester before 34, third trimester, it is D, third trimester from 34 to 40 weeks.
So the highest risk for this baby will be in the third trimester. This is correct. Within the 6 weeks from the delivery, 6 weeks mainly from the delivery, and mainly in the third trimester. Will be the highest infection, so it will be from 34 to 40 weeks. Next.
How much % of infant with local CNS and disseminated disease will present without skin, eye, and mouth involvement. Local CNS without eye.
How many babies will have CNS without any local? Nothing in the skin, nothing in the eye, nothing in the mouth, but they have herpes. And this herpes local,
30%?
either CNS. How
I'm
much?
not sure. Is it 30%?
60%. 60% of these babies will have CNS or disseminated herpes without any local herpes infection. Okay, next. The point here, any patient will come to you in the clinic. She has herpes, you will ask her, this is the first time or you have the same complaint before? This is primary or secondary? This is the most important point when you are solving any question regarding herpes. Gestational age of this patient, how much she is pregnant, and this is the first time or recurrent, because the greatest risk will be with the primary herpes. It will be more higher in the third trimester, within 6 weeks of the delivery, because this is because the viral shedding will be persistent, and this is we tell that the highest infection can happen with the birth delivery of the baby. Any patient with herpes, you need to refer her to gum clinic. Once you confirm by PCR that this is herpes, you will refer the patient to a gum clinic or another name, sexual health clinic for screening. But once you suspect herpes, you can start the treatment. Because the patient she will have been, so you can start the treatment, no problem. But once you confirm that this is herpes, you need to refer her for screening for other sexually transmitted infection, and also sexually transmitted infection, also screening for her partners, if she has multiple partners. Okay, next.
Pregnant women with painful vulval lesion and dysuria. What is the causative organism? It can be herpes simplex, D.
In the exam, you can face a single best answer. He will not tell you this is a question of the herpes. Will be a question in between the questions. Once he give you some lesion in the vulval area, and there is pain, sometimes he can put distension in her abdomen. So he wanted to give you a key of urine retention. So this will be a herpes, but he will not tell you, doctor, this is a question of the herpes. But sometimes in the exam you will be confused. Vulval lesion, painful, and there is something in the uterus, in the abdomen bulging. He wanted to talk about full bladder, so we are talking about herpes. So either dysuria or retention. So the other question in the exam can single best answer with urine retention and vulval lesion. So this is herpes simplex. Okay, next. Next.
Question. Okay, now. Patient has primary herpes at 6 weeks pregnancy, worried that this will affect her pregnancy. 6 weeks. Herpes increases miscarriage? No. Herpes not increases miscarriage. Herpes cause congenital anomalies. Herpes does not increase miscarriage.
Yes, this is important question. Any patient will come to you in the first trimester, she will be worried. Will cause miscarriage or no? This is a question you can face in your daily life from your patient. So you should answer her. So herpes in the first trimester, will not cause miscarriage, will not cause congenital anomalies, will not cause preterm, will not cause prom, will not cause IGR. And even the other important question, cyclovir, this will be safe in pregnancy or no? So it's safe, not cause also congenital anomalies. It's unlicensed to use in the pregnancy, but it's safe, and no any recording that it cause increase the birth defect. Okay, next. So now we have two important questions: increase miscarriage or no, and cyclovir can be used or no. Next.
How much % of cases where a woman presents with a first episode of clinical HSV infection will actually be a recurrent infection?
You will ask her, you have herpes before? She tell you, no, doctor, this is the first time. But after investigation, you discover that this patient is a case of recurrent. So how much percent? So this means that she has already herpes, but no symptoms. She didn't notice the symptoms. So how much percent of the women they will tell they are primary infection first time and they will be actually recurrent infection? How much?
25?
No, 15. 15% of the women, they will tell we don't have any history of the herpes before and this is the first time, but after investigation, they will be a case of recurrent miscarriage. Recurrent herpes. Recurrent herpes, the symptoms will be short. It can take from 7 to 10 days without antiviral treatment. So it's less than the primary one. Next.
Patient 21 weeks with herpes simplex, how much dose of acyclovir to be prescribed to the patient? Acyclovir 400 TDS for 5 days. And then
So
again from the it will be E. And again from 36 weeks until delivery.
So which one you will choose?
E. Last one.
E. Yes, E. So if the patient she has herpes simplex, this could be a question even in the part 3. A role player, she can ask you, I will take cyclovir until when? So she will take 5 days, and again you need to give her again from 36 weeks until delivery because this will decrease the risk of viral shedding. So you will give her cyclovir 400 3 times a day. Start from 5 days, and again you need to start from 36 weeks. We mentioned before that you sometimes you can be confused with the chicken box dose. Chicken box is stronger, so it will be double the dose. So 500 5 times per day for 7 days. Herpes week, so we'll make 400 3 times 5 days. If the patient she has the infection in the first and second trimester, you need to give her again from 36 weeks. This is cyclovir, a question in the exam. Also, you can give the patient paracetamol, you can give her lidocaine. This is for all the patient in the first and second trimester until 26 weeks plus 6 days.
Incidence of neonatal herpes if vaginal delivery after primary herpes. It is 41%. A.
Yes, if the patient she has primary herpes in the third trimester. We are talking about primary herpes in the third trimester, and she deliver normally. How much percent this baby will have herpes? It's about 40%. Very important percentage for the delivery. So this woman should deliver by cesarean section, not normal delivery.
Patient develop primary herpes in the third trimester. Mode of delivery will be cesarean section.
Cesarean.
If the patient she is developed primary herpes in the third trimester or within 6 weeks, this patient should deliver by cesarean section because this will decrease the risk of infection, because we mentioned just 41. So if this patient she has primary herpes and you deliver her by cesarean section, so this baby will need a specific monitor after delivery. So no, just you need to inform the team. You will inform the neonatology team that this patient she has herpes. We deliver her by cesarean section. So the doctor will do any investigation, swabs, no indication. If there is any treatment the doctor will give to her, no treatment is required. So this baby will discharge will discharge after 24 hours if there is no any problem. And just instruct the parent about good hygiene. Just to remember easily. So primary herpes, deliver by cesarean section in the third trimester. Just we need to inform the neonatology doctor, no investigation, no treatment. This baby after 24 hours, if normal, he can discharge, and just the parents will follow good hygiene. Sometimes if the patient she has BROM, she's planned, she agree for cesarean section, but she has BROM. If the BROM more than 4 hours, the benefit from cesarean section will be less, but still you will do cesarean section. You still will do. So if for one patient with herpes and she come by prom more than 4 hours, the benefit from cesarean section less, but still you will do for her cesarean section. Next.
A patient develops recurrent herpes in the 3rd trimester. Mode of delivery will be vaginal delivery. A.
Recurrent. So this is the difference. So primary cesarean section in the 3rd trimester. Recurrent, even in the 3rd trimester, she will deliver vagina. Correct?
Women with recurrent herpes, she wants to know the risk of neonatal herpes. If the lesions are present at the time of delivery, if delivered vaginally, it will be 3%, 0 to 3%. A.
Yes, 3%. If there is recurrent herpes, the risk of infection to the baby is 0 to 3. 0 to 3% only. So this patient, sorry, this is 3%. The risk will be about 3% because this will be a recurrent herpes. So the risk of infection will be only 0 to 3% because this is a recurrent miscarriage. Thank you, Dr. Asima, for sharing. We can take another candidate. Thank you for sharing. Another one, please, if anyone wanted to share. Another one, please.
Yes, I can.
What is your name, doctor?
I can try, ma'am. No.
Sumaya.
Sumaya. Okay, Dr. Sumaya. Okay, Dr. Sumaya. Continue.
Patient 28 weeks with herpes simplex. How much the dose of acyclovir prescribed to this patient? It's A. 400 mg 3 times for 5 days.
I think A.
Yes, you are Dr. Sumaya. Yes, when you are answering in the exam, be careful. I choose this answer. For example, I will look again. I will have a look again. I will have a look. Any other question? Any other more correct answer? This patient 28 weeks. We mentioned the patient 1st and 2nd trimester until 27 weeks plus 6 days. She will take 5 days. Again, we'll start from 30. Again, we'll start from 36 weeks. Once this patient reach 28 weeks, this patient, she will take 5 days, correct, 5 days, cyclovir. But you need to continue until delivery. This is the guideline. So it's easy. Any patient 1st and 2nd trimester until 27 plus 60 days, I will give her cyclovir 3 times per day for 5 days. Again, I will need to start from 36 weeks. This is rule. Another one,
Yes.
Patient with herpes from 28 weeks. I will give her 5 days. Same. But I need to continue the dose. Dose wrong. This is 400. Yes. Just a minute. I will correct.
Yes, that's why I didn't choose.
Yes. Just a minute. I'm sorry for this. 400 and continue until delivery. I write the answer. What?
Yeah.
Just a minute.
Now that will be the
Yes. Sorry. So this is only my fault.
Excuse me, why not E? That we restart at 36 weeks.
Actually, I have another PDF I prepared, but I don't know what happened, so I bring the primary one. So maybe there is some not corrected, but because the other one I don't know what happened, but it's lost from the desktop. Why not A? Because okay, it's correct.
No, why not E?
Correct
Sorry,
for E. Because this is for the second, it is for the 1st and 2nd trimester until 27 plus 6 days. Just review the guideline. The guideline there. Patient 1st and 2nd until 27 plus 6 days. This will be applied until 5 days. Again, you need to start from 36 weeks. Once the patient started 28 weeks, you will give her 5 days and continue until delivery. This is guideline. We need to follow the guidelines. This is what is mentioned in the guidelines. Okay. Sorry, I'm really sorry for this one. So I corrected it. So it's cyclovir 5 days and to continue it. So what is the gestational age? From 28 weeks. 3 times, 5 days, and then you continue until delivery. Next. Dr. Sumaya, next.
And although vaginal delivery should be avoided if possible, in women who deliver vaginal in the presence of primary genital herpes lesion, invasive procedure applicable fetal scalp to fetal blood sampling, artificial rupture of membrane, and instrumental
So you can use
delivery.
or no? So you can use or no? Primary herpes. You can use or no?
No.
No, so should be avoided.
Avoided.
And primary herpes should be avoided. Yes. So this is, yes, correct. You are correct. So next. Rules, just put rules. When you are studying any guidelines, just put main rules. If you have this main rules, you can solve any question in the exam. But if you don't put these rules, you will become confused. In the exam, you know the informations and there is much options looks like correct. But if you put rules, it will be easy for you.
If this is the case of the recurrent genital herpes, so in this case, the chance is less for neonate, so this can be used.
So can be used. So recurrent,
yeah.
You should know if he puts for you scenario for herpes and recurrent, and you should put an instrument, you will be confused. I will put or no, I will put or no. So primary, avoid. Recurrent, you can use. If it is necessary, you can use. This is another rule. So it's easy because the risk of infection drops to 0 to 3%, and this is will not increase. So it can be used if required. Next.
A woman present first episode genital herpes in the 3rd trimester. Type specific herpes simplex antibody testing is available it's 2 to 3.
Which one? Which one? Which one?
It's B.
I can't hear you. B, 2 to 3 weeks. So when you do investigation for the patient with herpes, you will take PCR from the fluids in the physical, and you will send also antibodies. So you will need to confirm this is primary or recurrent, and it will take 2 to 3 weeks. So what is why you need to know this information? What is the importance? Yes, this is important because if this patient, we just now tell if this patient in the 3rd trimester, you will do cesarean section for her. And we just mentioned that about 15% of this woman, they will be recurrent. So you can open one patient cesarean section and she is a case of recurrent. So you wanted to confirm. So I will take about 2 to 3 weeks to confirm. So you should know. You should know that it will take some time until you get the result. Okay, so what is the important questions if this patient come in labor?
A woman presenting with first episode of genital herpes in the 3rd trimester. And type specific herpes simplex antibody testing to herpes simplex 1 and 2 is advisable. Result will be taken 2 to 3 weeks. If patients start to have labor pain, you should deliver by. This is the case of first primary infection in 3rd trimester. We will go for
So what you choose? You choose what?
I need to check women is in active labor, or if she wishes to go labor pain. If it is labor,
So there is no counsel of the woman as an option. Yes, you are correct. I respect your discussion. Yes, we need to counsel the patient. This is correct, but this is not an option in the exam. I need to choose from the options there. Okay?
Yes. So in labor pain, I think it is active. If the delivery is imminent, I will give a antibiotic and go for vaginal delivery. If it is
antibiotic for what? Antibiotic for what? Antiviral, you mean?
For baby.
Antiviral.
Yeah.
Antiviral, you mean? Okay. The point here, this patient in the third trimester, she tell you, this is the first time, doctor, I have herpes. So you don't know, maybe 15% they will have recurrent, and they don't have symptoms before.
Yeah.
So you need to send the investigation and wait. If the result comes that this is a case of recurrent herpes, so this patient will deliver vaginal delivery. As is the case of primary herpes, you need to deliver her by cesarean section. I think this is so. If this patient by luck she came in labor to the delivery room, so you will deliver her as, just a minute because much noise, just a minute. So if this patient come before the result appear, you need to deal with her as a primary herpes. Why? Because the more risk will be the primary. So I'm not sure. So I will deliver her by cesarean section, and when the result come back, if she is a case of recurrent, I can modify the management according to the risk. Another rule. So this is another rule. Next.
Patient has primary herpes in the third trimester. She delivered vaginally, and her after what should be the management of her baby? HC. We will give the baby
start IV cyclovirin 20 milligram TID for 10 days while awaiting the result. Sometimes this patient, maybe she agree for cesarean section, but by unfortunately she come fully and she deliver. This can happen. Or she refused cesarean section. Whatever the reason, she delivered vaginal. So this baby, you need to give the baby. In my preparation, before my preparation for part 2, I will tell you because this was my confusing to me. I am confused between the cyclovir for the baby and cyclovir for the adult. So I'm thinking the baby will take the smaller and the adult will take the higher. No, there is the dose 20 milligram per kilogram for the baby. Remember in the exam, the 20, the higher dose for the baby, not for the patient. So this baby, if delivered vaginal and well, you need to start cyclovir 20 milligram per kilogram TID for 10 days until while the result. So this is a correct answer. So this patient you need, now this patient deliver, you will inform the neonatal doctor because we just mentioned the risk will be 41. This baby will need investigation. Yes, we need investigation. Swabs from the skin, conjunctiva, oropharynx, rectum should be sent for PCR. Lumbar puncture necessary if the baby will no need. And after this, you need to give this baby cyclovir IV 20 milligram per kilogram every 8 hours until the result appear. Sure, there will be infection control. If this patient asks you, I can breastfeed my baby, yes, she can breastfeed her baby, except there is herpetic lesion around the nipple. So it's better to avoid, and you will instruct the parents. If there is early signs of infection, just they will notify, like poor feeding, fever, or any suspicious. Next. Rules, another rules. Vaginal delivery, baby delivered well. Action. Primary herpes, vaginal delivery, baby unwell. Rules. This is rules. Okay.
Patient delivered primary herpes. Third trimester, she delivered vaginally and her baby unwell. What should be the management of her baby? In case of baby unwell, we do lumbar puncture.
So it's lumbar puncture. So this baby deliver vaginal delivery, primary herpes in the third trimester, baby unwell, so perform lumbar puncture. He will give you, this will be a question in the exam. This will be a question and you don't have rules. You read the guideline, but you don't put main points. So in the exam, you'll be confused. So just to put rules, you can solve the questions easily. Next.
Inshallah. A woman 38 weeks of gestation with primary herpes refused cesarean section and opting for vaginal delivery. Intravenous acyclovir, IV intravenous, mother, and then administration herpes immunoglobulin to neonate.
So what is your answer?
Yes.
C. So this patient, the previous one, we can't give her because she come already and she deliver. So no time to give her cyclovir. But this patient, she come and she tell, I don't want, and you counsel her about the risk and she choose. Patient, she has the right to choose for herself after counseling. So this is not a sharp. You tell her you are for cesarean section and she will agree 100%. She can refuse. You explain for her 41% your baby will have the infection. It's okay. I want to deliver vaginal. So in the end, the patient, she will decide for herself. You will not decide for her, just you will give her the recommendation of the guideline. But in the end, this will be the patient decision. Okay, so what is the dose? So cyclovir, IV for the mother and IV for the baby. The adult will be the 5, the baby will be the 20. Don't forget this point because some, like me, they will think the adult should be take the higher dose. Okay, so it's a 20 milligram per kilogram for the baby every 8 hours and for the patient 5 milligram IV every 8 hours and until waiting the result of the baby. Okay, next.
Patient has primary herpes in the first trimester. She delivered vaginally and after baby well.
We are talking the previous scenario about the babies in the third trimester, but this patient, she got the infection in the first trimester and it was primary. And you inform the baby doctor, this mother, she has primary herpes in the first trimester. So what should be done for this baby?
It's a normal postnatal care. We should we should keep the baby in observation. It's E.
It's normal. You look here to this chart. Patient, she has primary herpes in the first or the second trimester. You will give her the treatment, cyclovir 5 days. Again, you need to start at 36 weeks. This patient, she will deliver vaginally because we tell the herpes only in the third trimester, you will deliver her cesarean. And after she deliver, normal care because there is no any herpetic lesion. There is no any herpetic lesion. So what is the scenario? Normal postnatal care because she don't have any lesion at the delivery. Okay, next.
Rules. Patient has recurrent
rules.
Everything. In the third trimester, there is no lesion at time of delivery and delivered vaginally. It's also A.
So this patient recurrent miscarriage, recurrent. I don't know why I'm since yesterday discussion. I am thinking about recurrent miscarriage. Okay, recurrent herpes in the third trimester, and she delivered vaginally, and there is no any lesion at the time of delivery. So the same postnatal, you look again, recurrent herpes. You need to treat by the dose of the cyclovir, again 36 weeks to decrease. There is no lesion, so normal postnatal care. It's easy. If I know the rules, it will be easy. Next.
Patient has recurrent herpes in the third trimester and HSV lesion at the time of delivery and delivered vaginally. So here I will go for E.
Normal postnatal care. Postnatal discharge at 24 hours. If baby well, advise the parents regarding further management. This is copy paste from this is will come in the exam. Normal care or normal care and observe. So we are not confused which one. So you have to follow the guidelines. Same the guidelines you need to follow. Okay, next. So it's easy. Patient in the third trimester, primary herpes. She delivered her baby vaginally. Baby well, cyclovir IV. Baby unwell, lumbar puncture. If the patient she has primary herpes in the first or second trimester or recurrent miscarriage and there is no any lesion at time of delivery, normal postnatal. If this patient has a lesion at the time of delivery, so just normal postnatal care. But this baby you need to be discharged after 24 hours and advise the parents to come if there is any concern. It's easy. Next.
Doctor, can I share?
Yes, okay. Okay. What is your name? What is your name, doctor?
Nikita.
Okay, Dr. Nikita.
Patient with primary genital herpes in preterm pre-labor rupture of membranes, what will be the management? MDT, oral acyclovir 400 mg TID until delivery. Prophylactic corticosteroids if delivery is indicated within 6 weeks of primary infection, delivery by cesarean. No. MDT intravenous acyclovir every 8 hours, prophylactic corticosteroids if delivery is indicated within 6 weeks. No. MDT oral acyclovir. Primary and PPROM. It's D. It's the last one. Intravenous.
Should be A.
Intravenous A.
How much is the dose for the adult for herpes acyclovir? How much is the dose?
400 mg TID for 5 days. So she comes with PPROM. So we manage like expected management. We give corticosteroids, we give acyclovir, and then we deliver her by cesarean section.
So which
or we can continue. Actually, we can continue till 37 weeks.
So
we can continue till 37 weeks. It's expected management.
Yes, because this patient she has primary herpes and preterm. So if you deliver this baby, maybe also increase the morbidity and the mortality from the prematurity.
Yeah,
so
since she is not in labor, we can give her oral tablets, prophylactic corticosteroids, and if at all delivery is required, then cesarean. I'll go with A, ma'am.
C.
B, you need to give something stronger because she is primary and the brom. So the risk of the infection for the baby will be higher. So we will choose IV. IV, and we mentioned the dose for the adult will be 5 milligram per kilogram, 8 hours. And if this patient, she after 34 weeks, you will discuss with the patient regarding delivery. Despite this will be still the benefits from cesarean death, but still this patient you need to deliver her by cesarean section. So preterm, brom, primary herpes in the third in the current in this scenario, you will give her cyclovir IV, corticosteroid MDT. MDT will include the neonatology doctor also counsel the patient about the risk, and this patient she will need to deliver by cesarean section.
Ma'am, actually in PPROM with herpes, we give expectant management and we can continue it till 37 weeks. So we give her IV 5 milligrams per kg till 37 weeks, or like can we shift to
Not
tablets
37
again?
weeks, until 34. After 34, you can discuss with her regarding the outcome of this baby, and you can deliver her. 36 weeks, it will be from where you get the point of 37. From where?
No, because in PPROM, the new guidelines, it says like expectant management, we manage her, and we can pull it on till 37 weeks.
We are talking about patient with herpes. So until
Yes,
34, in this scenario, until 34, after this, you will counsel the patient again regarding delivery, and you will deliver her. So
though she is not in labor, we give her IV, ma'am?
Yes. This is copy-paste from the guideline. This is copy-paste from the guideline. Preterm, BROM, primary herpes, IV cyclovir, 5 mg per kilogram.
Excuse me, can we go back to the question?
This will be just this one. Gestational age depends on the current delivery, antiseptic cesarean will be remain, corticosteroid, implication of the preterm after the baby, if delivery indicated within 6 weeks. Yes,
Dr. Radha, I have one question for you.
Okay, if there is any doubt about one question, I will tell you. Because if we open discussion, we can't finish the session. Just write it in paper, and we can discuss it in the end, and we confirm it again from the guideline. Okay, so we can make the session more faster, because still we have much point. So we will do comment about this one 23 later. Okay, just move to the next.
Patient with primary genital herpes.
Okay, next.
Patient with recurrent genital herpes in pre-labor rupture of membrane at term. What will be the management? So she is in term.
She is term, rupture membrane, and she is a case of recurrent.
So she can deliver vaginally. So option A and B are ruled out. Option C, it says steroids, but at term I don't give steroids. And last option is expediting delivery. Yeah, so we expedite the delivery, ma'am. But however, we have to give her acyclovir as well.
Yes.
So
yes,
we don't.
We have to give her. But usually in the exam, we will give you the others. Just I will mute other mics, because please mute your mic, so we don't want to waste much time in muting all the mic, and again open. Open your mic again, Dr. Ankita. So this patient term. So if there is anything about cyclovir, look, usually he will not give something regarding the cyclovir. If cyclovir, then choose. If not, so the first one, we need to deliver this patient. The first option, I will deliver her, she is term. So I wanted to deliver her, because when the rupture membrane will be prolonged, and usually this will be the answer in the exam. Copy paste from the guideline. Okay, expediting delivery.
Yeah, D, ma'am. Yeah.
Ma'am, I just have a doubt.
Just please, every doubt, please, just wrote in the paper, because there is other issues will lose concentration. We can discuss in the end, no problem. Okay, just please continue, Dr. Ankita.
Patient with recurrent genital herpes in preterm pre-labor rupture of membranes less than 34 weeks. What will be the management? So it will be C. Yeah, she's recurrent. So she's recurrent, so no cesarean section. Then straight away I rule out A and B. Oral acyclovir 400 mg TID until delivery. Prophylactic corticosteroids if delivery by vaginal delivery. C, ma'am.
Yes, I can give her. She is a case of recurrent, so I can give oral. Recurrent miscarriage, the risk of infection will be less. She is preterm, I will give corticosteroid. So the option will be option C. You are correct. In case of BROM, this is copy paste from the guideline. In case of BROM before 34 weeks, there is evidence that expectant management is appropriate. including oral cyclovir 3 times to the mothers. After this gestational, it is recommended the management undertaken by relevant MRCOG guidelines on BROM and antenatal care corticosteroid administration to reduce the neonatal morbidity. So this is, we are talking about before 34 weeks. Before 34 weeks. After 34 weeks, discuss the risk and the benefits of immediate delivery and expectant marriage. So this is a point of counseling. You want to deliver after 34 weeks, or you want to delay more. So if you want to deliver immediately, there will be risk of prematurity. If you want to delay more, there will be risk of herpes. So in the end, it will be the patient decision. So I will give her the recommendation, discussion, risk and the benefit, and in the end she will discuss. She will decide for herself. So this will be done after 34 weeks. Next.
Patient 26 weeks with herpes simplex and HIV, a planned vaginal delivery. How much the dose of acyclovir to be prescribed for this patient? 26 weeks. So it's E, ma'am. Acyclovir 400 mg TID for 5 days and then start again from 36 weeks until delivery.
In HIV, the risk of prematurity will be higher. So this patient, you need to, this is the case we tell before, we will give from 36 weeks. If he bought HIV, you need to choose 32. You will start again cyclovir from 32. When the planned for vaginal delivery, because not all the patients with HIV, they will deliver by the cesarean section. So according to her condition, so we are talking about the patient planned for vaginal delivery in case of HIV, because the risk of prematurity will be higher. So not start from 36 weeks. In HIV, we will start from 32 weeks. Don't forget this information. Okay, next. So this is herpes. This is just the summary again. The patient you will look to first. Patient primary herpes or recurrent. Primary in the 3rd trimester cesarean section. In the 1st and 2nd vaginal delivery. Recurrent, she will deliver vaginal delivery. All the patient 1st and 2nd trimester, she will take cyclovir 3 times per day for 5 days. Again, you need to start from 36 weeks. From 28 weeks, you will give her cyclovir for 5 days and you need to continue until delivery. In case of HIV, if the patient planned for vaginal delivery and she has herpes in the 1st and 2nd trimester, you will not start from 36, you will start from 32 weeks. This is just the main point is in the guidelines. The guidelines really, it's important topics. But really it's tricky. There is some questions tricky. All the questions copy paste from the guidelines carry the important points, because what is the important points for us? This patient will deliver vaginally or cesarean. This patient, what I will inform to the baby doctor. What is the dose of cyclovir for the patient? And what is the dose of cyclovir for the baby? So just the main point is the guidelines are huge. If you go and read, especially if someone he didn't read before, it's huge information. But we need to do the rules. So in the exam, you can answer the question easily in the exam. We will move to another important topics. Also, you can face a 3 AMQ, very important topic for the exam. 3 questions about this topic. Even who prepared for part 3, we can face a question regarding endometrial hyperplasia. And endometrial hyperplasia, it is associated with multiple risk factors, in which the estrogen will be unopposed by the progesterone, and this will stimulate the endometrial cell growth, and with the time it will be endometrial hyperplasia. And there is 2 main classification now: endometrial hyperplasia with atypia or without atypia. What is the risk factors? The risk factors: obesity, body mass index high, anovulation like PCO syndrome, estrogen secreting ovarian tumors, this is also another risk factor. Drug-induced endometrial stimulation like tamoxifen, like the patient with breast cancer taking tamoxifen. So all these risk factors for endometrial hyperplasia. First, you need to confirm. How I will confirm? I will confirm by sample. So sample can be as an outpatient and by Bebel, and send histopathology to confirm the diagnosis. So if confirmed by diagnosis, I will do hysteroscopy for all the patient? No. I will do hysteroscopy if outpatient sampling failed, if it is not diagnostic, if there is endometrial hyperplasia diagnosed within a polyp or discarded focal lesion, if this is a case of the endometrial hyperplasia with atipia, and you are planned that you will do conservative, patient refuse hysterectomy or patient wanted to return her fertility, so you need to confirm again that this patient don't have endometrial hyperplasia or underlying cancer, so you need to do hysteroscopy also. So you can't do hysteroscopy for all the cases, otherwise this can need also to intrauterine adhesion for the patient. So you can't recommend hysteroscopy routine for all the patients. So in the question, you need to know first, this is a case of endometrial hyperplasia with atipia or endometrial hyperplasia without atipia, because this is will make the answer different. So if you have paper exam, you will do circle. If not paper exam, just by my eyes, I can tell this is with atipia or without atipia, because I can after this answer the question easily. Okay, I think you still with us, Dr. Ankita?
Yeah.
Okay.
Can I take, ma'am?
Women should be informed that the risk of endometrial hyperplasia without atypia progressing to endometrial cancer over 20 years is 4%. It's less than 5, yeah, 4%.
In the guideline, it's mentioned less than 5%, so it's 4%. So the endometrial hyperplasia with atipia will progress into cancer over 20 years in about less than 5%, which is 4%. This is very important number, very important number. Less than 5, so it can be 4. Okay. Endometrial hyperplasia without atipia can have spontaneous regress can happen, especially if there is something reversible, like this patient obesity, she is decreasing her weight. This can help her also to decrease, making the endometrial hyperplasia regress. Okay, sorry, because I don't know. This is the other PDF, so sorry for this. This is just important information. Hysteroscopy, they are talking about how much percent could be missed from the Bebel. So 10% of the endometrial pathology can be missed with inpatient endometrial sampling. So 10% of this is just a study about 10% of the pathology could be missed by inpatient endometrial sampling. Especially if they are talking about one patient with fertility, if you are taking frequent sampling, this can cause adhesion and can cause also Asherman syndrome, especially if you are doing frequent time sampling. So you should be careful regarding the sample, because this can cause adhesion. Yeah, sorry, because the first one. Okay. Next.
The most common presentation of endometrial hyperplasia is lower abdominal pain, abnormal uterine bleeding, or asymptomatic. It's abnormal uterine bleeding.
Yes, the most common presentation of endometrial hyperplasia is abnormal uterine bleeding. So this can heavy menstrual bleeding, intermenstrual bleeding, irregular bleeding, unscheduled bleeding on HRT. And we mentioned about the risk factors regarding body mass index, anovulation, estrogen secreting tumors, ovarian tumors, drug-induced endometrial stimulation. Okay, so the most common is abnormal vaginal bleeding, uterine bleeding. Okay, next.
A 60-year-old lady complains of heavy vaginal bleeding and was found to have endometrial hyperplasia without atypia. What is the first line of treatment? Continuous oral progestogen, intrauterine system, or total hysterectomy with BSO? We can go with total hysterectomy plus BSO, ma'am. C.
Patient endometrial hyperplasia without atipia. without atipia.
There is no need, there is no need for BSO. Bilateral salpingectomy can be done, but she has 60 years completed family. Total hysterectomy was the option, okay, but otherwise, should we go here for
Yes,
IUS then? IUS?
Okay, I will tell you. I bought it 60 years. I know. I bought it because I know that you will choose total abdominal hysterectomy. In the guideline, it's clear. Endometrial hyperplasia without atipia, first line treatment should be IUS. So you should tell, no, if old woman, I will remove her uterus. No, not logic. It will be applied for all, young woman and old woman. This will be for all. He didn't put you except if the patient old, you can remove for her uterus. No. So the rules, endometrial hyperplasia without atipia, the first line treatment will be IUS, except if the patient, she tell you, doctor, I can't follow up. You will tell her you need follow up, and biopsy, she tell you, no, I don't want follow up. So this patient is for hysterectomy. You are correct, but you will tell her the first line treatment, endometrial hyperplasia without atipia, IUS. IUS will be better than even oral progesterone, even postmenopausal. You look again, this is the chart. What is this? Endometrial hyperplasia. You can see the chart, correct? You can see the chart, this one. Endometrial hyperplasia without atipia. Address the risk factors, observation, first line treatment, IUS. He didn't put here except as the woman post-menopause. So this is kind for the patient. Why you decide to remove her uterus if there is first line treatment? Why you decide? Because she is old woman, but her right to take the first line treatment. Except if she refuse, she tell I don't want. So the first line treatment, because this patient, you will expose her to major operation. This is not easy to refer the patient for hysterectomy. This is risk operation with bleeding. So I don't want to forgive to her. Okay. So this one will be the IUS, regardless the patient age. Next.
Ma'am, shall I do?
Can
I share,
yes,
ma'am? Can I share?
Ma'am, can I
okay,
share?
what is your name? What is your name, doctor?
Ramya,
Ankita,
Dr.
ma'am.
Ramya.
Okay, Ankita, we will give others chance to
Yes,
share.
ma'am.
Okay, others. What is your name?
Dr. Ramya.
Okay, Dr. Ramya.
60-year-old lady complained of heavy vaginal bleeding and was found to have endometrial hyperplasia without atypia. Patient refuses IUS. Then we can go for oral progestins, ma'am.
Yes, she refused IUS. So you give her other options. Still, she has. What is this? What is your answer? First, I'm helping. What is the other? What is your? So which one? A or B?
Continuous
So which
progestogens, nor
one?
it is from B.
B, continuous. So we will give B because continuous. We will not give cyclic for the patient with endometrial hyperplasia. So if she refuses IUS, there is other options. You will give her other options, either noresysterone 10 to 15 milligram per day, or medroxyprogesterone will be 10 to 20 milligram per day. If she refuses IUS, because this is another options, and we will tell her it's less effective, but still this is option for her. Okay, this is, she will take progesterone at least 6 months. Okay, next.
Yes, ma'am. It will stop after 6 months.
Next.
A 45-year-old lady complained of heavy vaginal bleeding and was found to have endometrial hyperplasia without atypia. Patient start progesterone tablet. What will be the follow-up for this patient? We will do endometrial biopsy every 6 months, ma'am, until 2 or more consecutive negatives at 6-month intervals. It is B, ma'am.
B. So endometrial biopsy, cases of endometrial hyperplasia without atipia. After treatment with progesterone, we need to take endometrial biopsy every 6 months until 2 consecutive negative, 6 weeks, 6 months apart. So it's correct. B. Another rule. If you have rules, you can answer easily in the exam. So the patient So the treatment with the patient, the treatment will be either IUS, the first line treatment, or oral progesterone. For example, patient, she tell you, doctor, okay, I'm agree for IUS. You insert IUS. She tell you, doctor, I don't want to have a children now. So she can continue the IUS for 5 years because she don't want to have a children, and this will decrease the risk for relapse. But if she wanted to conceive, so at least this IUS should be there 6 months until negative biopsy. After this, she can be removed. Some they are thinking if the patient wanted to conceive, you will not insert for her IUS. No, you wanted to treat the patient as soon as possible because this patient also wanted to conceive, so you wanted to give her effective. But this is contraception. Yes, this is now not contraception. This is a treatment. This is a treatment, and you wanted to give her effective treatment. Effective treatment will be IUS. Will be IUS.
عشان الحديقة ما ماشيين السطور قلنا ولا ما قلنا؟ طيب
I will mute all again.
Sorry, Dr. Gada, we can't hear anything.
A 48-year-old lady complained of heavy vaginal bleeding and was found to have endometrial hyperplasia without atypia 1 year ago, and Mirena was inserted. Her BMI was less than 35. She had 2 people biopsies 6 months apart. They were normal. So BMI less than 35, we can discharge her from follow-up. So endometrial hyperplasia without atypia. 2 consecutive samples were negative, and BMI is less than 35. We can discharge her from follow-up. A. Ma'am, no voice is heard.
Dr. Gada, you mute yourself as well.
It's clear now. My voice clear?
Yes, ma'am.
Okay, so you are correct. You are correct. 2 negative biopsy, and patient use IUS. Body mass index less than 35. Correct. So you will need to discharge this patient. So what about if this one more than 35? What will be the answer?
Then we have to follow up yearly annual follow-up, ma'am.
Annually, yes, because the body mass index higher than 35, so you need to follow up here annually. This is from the chart. If you look here the chart, if the patient 35 equal or more, this patient need annually follow up after 2 negative consecutive biopsy negative 6 months apart. Next.
A 42-year-old lady complained of heavy vaginal bleeding and was found to have endometrial hyperplasia without atypia 1 year ago. Mirena coil was inserted. Her BMI is less than 35. She had 2 people biopsies 6 months apart. They were normal. She don't want to conceive. Mirena coil should keep at least for 5 years, ma'am.
Yes, she don't want to conceive, and just now we mentioned Mirena can be kept because this will decrease the risk of relapse because she is conceive, so at least 5 years. Excellent. Next.
A 48-year-old lady complained of heavy vaginal bleeding and was found to have endometrial hyperplasia without atypia 1 year ago. Mirena coil was inserted. BMI is more than or equal to 35. 2 people biopsies 6 months apart, and they were normal. Then it is C, ma'am, annual biopsy and review.
Why?
Because the BMI is more than or equal to 35.
So if her body mass index in this scenario 25, what you will choose?
I will discharge her from follow-up, ma'am. If BMI is less than...
No, you will not discharge her. Yes, you are correct, annual, because body mass index high. But any patient... sorry, this is Mirena. Sorry, okay, this is Mirena. Okay, this will be the common one. Yes, correct. You are correct. You are correct. Okay.
BMI 25 is normal.
Yes, you are correct. Okay, and because I'm talking about the next question. Okay, no problem. Correct. Next.
A 49-year-old lady complained of heavy vaginal bleeding and was found to have endometrial hyperplasia without atypia 1 year ago. And oral progesterone started at the time of diagnosis. Her BMI is less than 35 and she had 2 biopsies 6 months apart and normal. She continued progesterone for 6 months. So we can discharge her from follow-up, ma'am.
Why would discharge her? Why would discharge her from the
BMI is
less than
35,
35? But what she is using? What she is using?
She's using progesterone for 6 months.
Yes, so she used oral progesterone. So oral progesterone, if you use oral progesterone, regardless the body mass index, this is what I wanted to mention. If the patient you are giving her oral progesterone, don't look to the body mass index. This patient, she will have annual biopsy. Look here. I will again show you this one. Body mass index 35 or more. Or you look to this or, you see this or no?
Oh,
you
okay,
can see this or?
Yes,
or treated with oral progesterone after 2 negative biopsy, this patient, she will need annual endometrial biopsy. So once the patient you give her oral progesterone, this patient, she will need annual follow-up. It's clear regardless her body mass index. Easy?
So for LNG only, this body mass index is important. For oral progesterone, so we need to keep on annual follow-up. Okay.
Yes, so once I see oral progesterone, I will not look to the body mass index. This patient will need annual. But for the others like IOS, this patient, if body mass index 35 or more, she will need only. Others, no need, discharge. Easy?
Easy, ma'am, easy.
Okay, next.
A 43-year-old para 2 lady has BMI of 46. She complains of heavy vaginal bleeding and the people's biopsy shows endometrial hyperplasia without atypia. She had Mirena coil inserted 2 years ago, but the symptoms have recurred. If the symptoms have recurred, then we have to proceed for total laparoscopic hysterectomy with conservation of ovaries, ma'am.
Yes, if the patient she has recurrence of the symptoms, this is one of the indication of the hysterectomy. Hysterectomy better laparoscopy. I will conserve the ovary or no, this is counseling. If you see one options with counseling regarding ovaries, it will be better option. Why? Because I will tell her that she's young age, premenopausal. I will counsel her. If we are keeping your ovaries, there is risk of ovarian cancer in the future. If we are removing your ovaries, this means that you will have menopausal symptoms. You will need also HRT. So it's a matter of discussion and counseling. And in the end, the patient will choose for herself. So she has the right to agree or refuse. So recurrence of the symptoms, this is one of the indication of hysterectomy. I think it's mentioned also here. I can't see the, because very small. What is very small? Resistant regression. Yes, here. Total abdominal hysterectomy plus or minus bilateral salpingo-oophorectomy if ongoing abnormal uterine bleeding. So this is one of the indication of hysterectomy. So again, you need to look again endometrial hyperplasia without atypia, first line treatment IOS, second line treatment oral progesterone. If the patient tell you, you give her the option and she tell you, doctor, no, I don't want, I can't come for follow up. She tell you, I have hysterectomy, so you can discuss with her regarding the rest, especially if the patient not willing. She is not willing for follow up. She can't come for follow up. This patient IOS, I will look to the body mass index. If it is 35 or more, this patient, she will need two consecutive sample 6 months apart, and after this, no need for any discharge the patient. If the body mass index 35 or more, annual follow-up. 35 or more, annual follow-up. Progesterone oral, all the patient progesterone oral, regardless the body mass index, because the risk of relapse high. So she will need annual smear, annual. If the patient she has ongoing persistent of the symptoms, this is indication of hysterectomy. I will mute again, please. No problem. I think every time I will open and mute, it's difficult now. Please open your mic again so you can continue. We will move now to the patient with endometrial hyperplasia with atopia. With atopia. Okay, where are you?
Yes,
Who's
ma'am. A
this woman?
42-year-old para 3 woman is diagnosed with endometrial hyperplasia with atopia. She had an intrauterine system. Her follow-up endometrial biopsy at 12 months show endometrial hyperplasia without atopia. So it is a regression after 1 year, ma'am.
So?
But even then, we'll proceed with TH with TH with C, ma'am, total laparoscopic hysterectomy with conservation of ovaries because it is with the atopia.
So you choose C.
C, ma'am.
Yes, because if persistent, some they are thinking once there is no atopia, we will no need to, we can continue the treatment. Persistent hyperplasia. The idea in persistent hyperplasia, maybe it's without atopia, but still it's persistent. So once you see persistent hyperplasia, even it's now without atopia, still this patient for hysterectomy. So some they are thinking because now she was before endometrial hyperplasia with atopia, and after 1 year it's endometrial hyperplasia without atopia, so no need for hysterectomy. No, just to follow the guideline. Persistent hyperplasia even without atopia after 1 year, this is an indication for hysterectomy. So it's correct. Supracervical hysterectomy should be avoided to ensure all malignant disease is eliminated. Okay. Next.
Atypical hyperplasia has also been associated with the rate of concomitant carcinoma of up to how much percentage in women undergoing hysterectomy? It is B, ma'am.
It's a famous question. This is very famous question. How much percent one patient she has endometrial hyperplasia with atopia during hysterectomy? How much chance this patient could have a cancer? It's 43. This is very famous and very important number. Okay, correct. Next, concomitant cancer. Okay, next.
58-year-old complaining of postmenopausal bleeding. She is found to have endometrial hyperplasia with atopia. What is the first line treatment of her condition? She is 58 years postmenopausal. So we will go for a total hysterectomy with BSO, ma'am. C.
C.
Yes, ma'am.
Total hysterectomy, bilateral salpingo-oophorectomy.
She is postmenopausal.
Yes, she is a case of postmenopausal, so we will recommend for her the total hysterectomy, bilateral salpingo-oophorectomy. Laparoscopy will be better because this shorter hospital stay, this post-operative pain, quicker recovery. Endometrial ablation is not recommended in the treatment of hyperplasia because in the end it can preclude in future endometrial cancer. Okay, next. We can share. Anyone more wanted to share? Thank you, Dr. Ramya, for sharing. Anyone more wanted to share?
Can I share?
Dr. Yes, Dr. Umm Hassan, how are you?
السلام عليكم. بسم الله الرحمن الرحيم. 58 year complaining of postmenopausal bleeding. She is found to have endometrial hyperplasia with atopia. She refused total hysterectomy and BSO. D. IUS.
D. Don't think that the guidelines is must patient follow. We are follow the guidelines. We will give the recommendation to the patient, but in the end, it's her decision. So you tell her you are a case of endometrial hyperplasia with atopia. The Green Top guideline recommend hysterectomy. She tell you, I don't want. Yes. I don't want hysterectomy, but this is the first line treatment. Yes, this is the first line treatment, but I refuse. I don't want. So you should give her another. So you will counsel her about the risk, and you will offer her IUS as an option for treatment. So this will be the option if she refuses hysterectomy. Okay, next.
Yes. How should postmenopausal woman with atypical hyperplasia refuse hysterectomy? IUS inserted. What will be her follow-up?
Patient atypical hyperplasia. Forget that we are now in the endometrial hyperplasia with atypia. Don't be confused regarding the previous one. We are now in another endometrial hyperplasia with atypia.
Yes. I think should be 3 months.
Every 3 months until 2 consecutive negative
biopsies are obtained.
Then every 6 to 12 months until hysterectomy performed.
Yes, B.
Correct. Correct. This is very important. This is rules. This is rules.
Yes.
One patient, genital hyperplasia with atypia, she refused hysterectomy, IUS inserted. What will be the follow-up? She don't want to conceive, so this patient every 3 months until be careful from 2 consecutive negative biopsy, and after this 6 to 12 months, and you will inform her. You will inform her because you will tell her you need to come frequent times. Really? Yes. You need until two negative biopsy, and again every year, 2 times per year. So she will tell, no, you can't do hysterectomy for me. I agree now.
Better.
Okay.
58-year complaint of postmenopausal bleeding. She is found to have endometrial hyperplasia with atypia. She refused total hysterectomy and BSO. This is repeated.
So what is the answer?
IUS.
I put this question specifically to give you a shock. You know, a shock. Because in the exam, I want you to concentrate. Yes, answer the question. It's IUS. This is correct. But there could be another more correct option. So I want to from you to alert. You know, electrical shock when I choose one answer. No. I will go up. Gada, tell us. Look to the others.
Thank you very much.
There is one option. Yes, there is one option to counsel about. Yes, it's correct if she is refused, but you need to counsel her. So which one will be correct? I will give her IUS first, or I will counsel about this. I will counsel first. I will tell her this will be risky. This concomitant cancer. You will need follow up. You will have frequent times. She tell no, I agree. I want hysterectomy. So be careful. This is just I put it as a shock for all of you, not only for this question, just to be alert in the exam. Okay? So counsel about it's not a repeated question, so I leave you to think that it is a repeated question. Okay.
Thank you for shocking us. Okay, 64 years old Noribra lady complaining of heavy vaginal bleeding. She is found to have endometrial hyperplasia with atypia. She wants to retain her fertility. IUS inserted. What will be the follow-up? B.
B. Review interval every 3 months until 2 consecutive biopsy, and then follow up every 6 to 2 months. It's recommended until hysterectomy performed. She wanted to retain her fertility. So it's a correct answer. It's a correct answer. But you look what is this one before I move to the next. She wanted to retain
her
fertility. You don't forget this word. Okay?
Yes.
Next.
36 years old Libra lady complaining of heavy vaginal bleeding. She found to have endometrial hyperplasia with atypia. She wants to conceive soon.
She wanted to conceive soon. Previous patient, she wanted to. What is this? This is another thing. No, still. Okay, this is another question. So you choose what?
E.
Which one?
E.
No, friend, help. No, don't help her. Okay, what is the answer?
Can use surrogate mother.
Surrogate mother? We will put, you will put option in the exam. This will be very nice. I will put, no, I have another more correct option, doctor. I will put this option and you took it. The one there, they will suicide.
iOS.
iOS. Yes, we just now mentioned. If patient, she wanted to, even she wanted to have baby, we need to give her something stronger. So the stronger one will be the iOS because we want to treat her faster. And after treatment, before treatment, we need to counsel the risk. But this is the first line. There is very important point. When you are counsel this patient, she wanted to conceive, you will tell her the recommendation will be hysterectomy.
Yes.
But as you wanted to conceive and you want to have a baby, so we will have a treatment for you. But I mentioned for her that already the first line treatment hysterectomy in her condition, but as she wanted to return her fertility, we can have options for you. It will be iOS after treatment and regress endometrial hyperplasia. We'll refer her to fertility clinic, and after she completes her family, hysterectomy should be done. Next.
36-year-old non-Libra lady complaining of heavy vaginal bleeding. She has endometrial hyperplasia with atypia. She wants to conceive soon. iOS inserted. How should be followed?
She wanted to conceive soon.
Yes.
She wanted to conceive soon. Okay, every 3 months. Then
until two consecutive biopsies.
So you choose B.
B and D. Yes, B.
In this patient who wanted to conceive soon, she wanted to conceive. There is difference between the patient who wanted to return her fertility. Any other patient, if he put in the scenario patient wanted to conceive, she wanted to conceive soon, so this patient you need only one only.
Baby.
Once you have one, you are in hurry. Remember, you are in hurry. She is in hurry. She wanted to conceive in hurry. So you need only one. Don't forget this one. Only one biopsy enough, and you will refer this patient immediately to fertility center for assisted reproduction, because if this patient wait for spontaneous natural pregnancy, the risk of relapse will be higher. So remember, I'm hurry. So need one only. Refer fertility center. This patient assisted reproduction because spontaneous. Because if we need for natural conception, the risk of recurrence high. It's easy or no? So if patient, what is the? I want to again to look again to the question. So the patient with hysterectomy who refused hysterectomy, we insert her iOS, and we mentioned for her she will come 2 times every 3 months until 2 negative biopsy, and after 6 to 12 months. And we mentioned patient wanted to retain her fertility. She didn't tell I wanted to conceive now. Be careful from the words. She didn't tell you I wanted to keep my uterus. You wanted to conceive now? No. She wanted just to retain her fertility. So it will be same follow-up. But who tell you I wanted to conceive soon? So I will need only one biopsy only every 3 months. Negative, just one negative. Immediately I will refer her to fertility centers. This is rules. It's not difficult. You should understand the guideline, so it will be easy for you. Okay, next.
Okay. Woman with atypical hyperplasia, the risk of coexisting ovarian cancer was up to 4%.
4%. You have one patient endometrial hyperplasia with atypia. How much chance this patient could have coexisting ovarian cancer? It will be about 4%. 4%, and there is 2% that could this patient, she has stage 1 endometrial cancer. There is could this patient could have metastasis about 0.5%. Next.
35 years old with BMI 35 and oligomenorrhea is diagnosed to have polycystic ovarian syndrome. Regarding her risk factor, of developing cancer. How much the endometrial thickness is unlikely to be hyperplasia? Less than 7, less than 8, less than 10.
One patient PCO syndrome, she don't have, she
Yes.
have amenorrhea all the time, no withdrawal bleeding, and you are worried about endometrial sickness. So how much the endometrial sickness will be unlikely this patient she will have
Less than
hyperplasia?
7. Less than 7.
Less than 7. So from 7, this patient could have hyperplasia. For who?
Yes.
For patient with patient we don't have with oligomenorrhea, patient don't have withdrawal bleeding. So it will be this is from the guidelines of the PCO syndrome, and just to put it because this is also important point just to remember it. I think this is this is very important chart. You can have frequent questions, and every word in this chart you can have a question in the exam, and some still they can answer the questions wrong. Especially if you are giving one patient oral progesterone and they put the body mass index low. So you thinking that the body mass index low, no need. Just the patient to take oral progesterone. This patient after 2 negative biopsy, she will need annual follow-up. So be careful. Every patient, she will have first line treatment, second line treatment. So endometrial hyperplasia without atypia, first line treatment IUS, second line treatment oral progesterone. So this is the recommendation. Patient endometrial hyperplasia with atypia, first line treatment hysterectomy. But remember, this is the recommendation of the guideline. So if the patient refuses, she has the right to refuse. So you should give her another option. So endometrial hyperplasia with atypia, you counsel about the risk, and she tell you, I don't want hysterectomy, doctor. So you should offer for her, counsel the risk, and after this you will tell her there is other options for you. It will be IUS, it will be better, and the second one will be oral progesterone, the one continuous. And you will need follow-up until 2 negative biopsies, 3 months apart. Every 3 months she will come until 2 negative, and after this you will need follow-up every 6 to 12 months until she decides for hysterectomy, or she can't willing for the follow-up. She will tell you, I can't follow up all this appointment, so you can do hysterectomy for me. The patient with endometrial hyperplasia, she wanted to conceive with atypia. This patient, you are in hurry. So if she wanted to conceive as soon as possible, so this patient you need only one biopsy, sample biopsy negative. After this, you will not need to wait for natural conception, because if you wait, this patient will be high risk to have relapse. It's easy if you put rules. It will be difficult if you just read all the information. All will be confused, and you should be clever in the exam. If you see one question answer and you answer and you are 100% that this is the correct answer, just have a look again about all the answers there. Sometimes you can answer the questions by this way. Oh, I see it. Like the patient come before, the patient with GB, and it's mentioned that she has UTI, and she started to have acute pain. Anyone read the question? Because it's written the patient, she has right chest pain, so it's angina. Right chest pain, it's from long time we know right chest pain, it's angina. I will choose angina, but it's written up acute chest syndrome in the option. Acute chest syndromes, she visit her GB, she has urinary tract infection, so this is acute chest, this is a case of sickle cell disease. So you can answer the question even by looking to the other options if you are confused in the start. This is the information.
Hello?
The informations. And everything is possible. There is nothing impossible. For me, nothing impossible unless you think it is.
دكتورة غادة لو سمحت. Excuse me, Dr. Ghada.
Dr. Ghada.
Yes, Dr.
Sorry, I'm confused about
Please,
question.
Dr. Ghada, I wanted to ask a question.
We will take one by one, Dr. Iman first. Yes, Dr.
Okay.
Iman.
Dr. Ghada, the ideal treatment for endometrial hyperplasia with atypia is total hysterectomy plus or minus bilateral salpingo-oophorectomy. When
Yes.
we can preserve the uterus for a woman with endometrial hyperplasia with atypia. I mean, if there is a regression, we can continue on the treatment, yes?
You are talking about endometrial hyperplasia with atypia, correct?
Atypia, yes. Yes, I mean,
first line
I know.
treatment.
Hysterectomy with or without bilateral salpingo-oophorectomy. Yes.
Correct.
I need to ask when we can continue on IUS or progestogen as a treatment if there is a regression, صح? If there is a regression.
Okay. First point, why I will not remove the uterus? This will be the first question. Either the patient she don't want, because some are thinking if the patient post-menopause, I need to remove her uterus. No, she can refuse. She is post-menopause. She is 6 years, but she refused. This is her right.
If there is a scenario for a patient that want to preserve her uterus, whatever perimenopausal or postmenopausal, but she wanted to preserve her uterus, she don't want to make hysterectomy, and I bought for her IUS, and there is a regression. What is meant by regression? Regression, it means endometrial hyperplasia without atypia or the endometrium return to normal, because there is a question.
Just any patient with endometrial hyperplasia with atypia, make it as a rule. First line treatment hysterectomy, unless patient refuse or patient want to return her fertility. So what will be the follow-up? Follow-up will be every 3 months until 2 consecutive biopsy negative. And after I have 2 sample negative, this patient need to come follow up every 6 to 12 months until hysterectomy done. Until hysterectomy.
The rule is hysterectomy.
Hysterectomy in the end, until she agree for hysterectomy or she complete. This is the end. There will not be any. You mentioned you wanted to tell it's treated, so we will leave the patient and remove. No, there is very high risk this patient could develop cancer. So the follow up every 3 months until 2 consecutive negative biopsy, and after this every 6 to 12 months, and after this until she agree for hysterectomy or she completes her family. So the end hysterectomy.
Yes, even there is a regression. No problem. The end is hysterectomy also.
Yes.
Also hysterectomy.
Once diagnosed with atypia, the end hysterectomy.
Okay. Thank you, Dr. Ghada. Thank you so much.
Yes,
Dr. Ghada,
ma'am,
regarding her,
can I ask now, please?
I think you want Dr. Her name May. She is the one asking you before, Dr. May.
Yes, please. Thank you very much, Dr. Ghada. My question, can we go back to question 48, please?
48, please. Okay, just a minute.
I just had a confusion about.
Today I am searching, I'm searching for the PDF. I am lost from the desktop. I don't know what happened. Then this is another one, primary. But good that there is another one. Yes. This one?
Yeah, so what's the risk of what? I misunderstood what is asking about.
I can't hear you.
Sorry, I did not understand what is he asking about.
You have
what
one
risk?
You have one patient in the clinic now. You take sample by bubble biopsy, and this patient, she has atypical hyperplasia. How much chance this patient she could have coexistent ovarian cancer? 4%. So you need to exclude this patient she could have ovarian cancer. Chances that this patient she could have ovarian cancer.
So we do CT?
If patient with endometrial hyperplasia not willing to have hysterectomy, you should exclude. You do CTs, you do CA125 to exclude coexisting cancer and ovarian cancer. This is the recommendation also in the guideline.
Thank you.
It's here. You look. Investigation, MRI, CT, transvaginal, serum CA125 for the patient who are planning to return her fertility, because there is a chance of concomitant cancer, there is a chance of concomitant ovarian cancer, and this patient wanted to return. So how I will confirm that she is safer for her to continue? Maybe there is ovarian cancer, so how she will preserve her fertility? So it's difficult. Okay, next.
Dr. Ghada, regarding the herpes, if at all the PPROM is there at 28 weeks, so we will be waiting for the patient
which question, please? You remember? You remember the question?
No, I don't remember. I'm just asking the question. I'm just asking.
23. I think it was 20.
23. Okay.
Yeah.
23.
Regarding
okay.
if the patient has PPROM at 28 weeks, shall we wait till 34 weeks or can we wait till 37 weeks for the delivery? What's
Dr. Kausar, I can't hear you. What you are telling, I can't hear you, Dr. Kausar. There is much interruption in your voice.
Is it clear now? Hello? Hello?
Excuse me, we can't hear anything.
I think Dr. Ghada, maybe she has a problem. Dr. Asif, can you help, please? Because we need to ask a couple of questions as well. Hello?
Hello? Sorry for this interruption. Can you hear me now? Hello? Hello?
Yes, we can hear you, Dr. Ghada. Yes.
Yes, ma'am.
Sound is clear or no?
Clear now. Yes.
Clear.
Sorry for this interruption because there is problem in the internet. Who is asking the questions? Last questions? Dr. Kausar, sorry. Dr. Kausar, who is asking the question regarding the prom? Dr. Kausar? Anyone has any questions?
Hello, ma'am.
Anyone of you? Yes.
Ma'am, one question not related to endometrial hyperplasia, but in general, I had seen one question, a postmenopausal patient, 60-year-old, with endometrial thickness of 3 mm for postmenopausal bleeding, and there was on sonography there was a fluid in the endometrial cavity. There were options of reassurance, do hysteroscopy, and do endometrial biopsy, and the answer was do reassure the patient.
Was old, very old recall. Come from one talk articles. There was a chart there that the patient, if the endometrial thickness less than 4 millimeter, I think there is someone asked this one before in the group, and was recall from old good talk, and it was mentioned in this talk that this patient should have hysteroscopy. But I think you should fill the new talk. But I can post for you because this is question I think maybe 4 years or 5 years before, and was related to this talk. And I posted the chart. It was there, but it was related to all the talk.
Okay, ma'am. Okay, ma'am. Thank you, ma'am. Ma'am, one more question.
Please, questions related to the session.
Dr. Ghada, salam
okay, thank you,
alaikum. Can I ask you about this question? What you have posted here on the screen?
Yes.
On behalf of Kausar, Dr. Kausar, I'll ask this question. This question is patient with primary genital herpes in preterm, pre-labor rupture of membranes. What will be the management? She wanted to know what exactly is the option which is appropriate. So is the option here, because it's a primary genital herpes, A, the option is A?
Oral, it's in the guideline IV. Rupture membrane, primary genital herpes, you can search in the guideline. If I'm wrong, correct me. It's in the guidelines. Preterm from
you're perfectly all right. It is that, then B it is. Okay.
So it's IV cyclovir. Be careful. We don't want to move from the main track for the exam. This is an exam, so I wanted to pass. There is pass or fail. So I wanted to know what is the main points in the management. Primary herpes, preterm brom, MDT, IV, cyclovir 5 milligram per kilogram every 8 hours. Other treatment according to the preterm for the brom. And this patient will deliver by cesarean section, because even you will give this patient time more than maybe days, and the benefit from the cesarean section will be less, but still you will deliver her by cesarean section. The point, when I will deliver her, after 34 weeks, you will counsel the patient, just to counsel.
Okay, what's 5 minutes?
Yeah, thank you very much, Dr. Ghada.
Ma'am, so we give IV isoclovir till 34 weeks?
34 weeks, you will say, after 34 weeks, it's written, you will counsel the patient about the delivery. Counsel means
suppose she has PPROM at say 25 weeks or 27 weeks. Then till 34 weeks, then she will get acyclovir IV dose only?
25 weeks. So you are talking about primary herpes in 25 weeks. So okay. So this patient, if she is a primary herpes at 25 weeks from, could be a difficult question, but I am not sure from this answer. From preterm, because this will be second trimester. I will take the point of cyclovir, because when you will deliver her, you will give her cyclovir from 25 until 34. It could be a difficult.
No,
I'm not sure
I wanted to.
Yeah, then
and also one more.
Then couldn't oral acyclovir be better?
I will tell you. Okay. Primary herpes in general, in the first and second trimester, you are giving 5 days. Okay, because this patient near to the delivery, she will have the infection during delivery. So my idea in the first point is oral. It will be IV or oral. You will continue on oral. I'm not sure from this point. I can't tell a certain answer for this. But in the exam, he will not give you a complicated scenario. He wants from you to know the basics. Either in part 1 or part 2.
Can't hear you, doctor.
Can't hear you, madam.
Dr. Ghada, can't hear you.
Not audible.
Yes, ma'am, not audible.
Sorry again for interruption. The point of the question, don't put complicated questions. What one of the could affect your performance in the exam that you are putting complicated scenario. If patient usually the preterm prom, it will come in the after 28 weeks. It will be difficult to give you scenario 25 weeks prom or herpes. And if he wanted to kill, he will kill you better. Yeah? So it's difficult to give you a questions in this age. Usually he will give you from 28 weeks. So that with 28 weeks, MDT, IV, cyclovir, and until 34 and the counsel. But 26 and the primary herpes and the prom, how much specifically cyclovir IV and or oral, it's not mentioned clearly in the guideline. Okay. Any other questions?
Okay, ma'am. Yeah, I wanted to ask one more
I need that one.
Like, if in endometrial hyperplasia, it is without atypia, and she wants to conceive soon. Like with atypia, she wants to conceive soon. You said like 3 months, and after 3 months, one negative, we ask her to go for IVF. Like, is there anything
Yes.
like that for without atypia, endometrial hyperplasia without atypia, and she wants to conceive soon?
Okay, the guideline in the patient endometrial hyperplasia without atypia wanted to conceive, we will give her IUS. And we are not in hurry because this patient is not at risk also for cancer. Yeah, the risk of cancer will be less. She is at risk. But the risk will be less. But this patient, she will need 2 endometrial biopsy, consecutive, 6 months apart negative, and after this we will remove the IUS if she wants to conceive at least 6 months, and she can conceive. No one in the patient without atypia, there is no one biopsy, all 2 biopsy for all the patients,
Okay,
either she wants to conceive or not. It's clear in the guideline.
Yeah, thank you, ma'am.
Dr.
We
Iman,
cannot give oral for want to conceive. Oral for.
Dr. Iman. Dr. Iman,
Hiya,
what?
Dr. Ghada, I need, yes, I need to ask a question, please.
Dr. Iman, just a minute. Oh, guidelines is very clear. It's written patient want to conceive, IUS is the first line treatment. It's written clearly. This is not my opinion. This is the guideline. IUS, because IUS is more effective than oral. Why you want to give oral? Some thinking because oral, it's a patient want to conceive and the IUS is contraception. Yes, but IUS, it is effective treatment. You need to treat the patient, otherwise she can't conceive. So you will give her IUS until treatment, and after this you will remove and she can conceive. Yes, Dr. Iman.
Yes, Dr. Ghada, I want to ask if a patient has vaginal bleeding and we make a biopsy using Bebel, and the result of biopsy endometrial hyperplasia with atypia. We need to confirm this by hysteroscopy, or we will take this for treatment either by hysterectomy directly or.
I will tell you, patient with endometrial hyperplasia with atypia, no need to do hysteroscopy if this patient agree for hysterectomy, because already you will do hysterectomy for her and you will send for histopathology. But if she tell you, doctor, I don't want to remove my uterus for any reason, either she is post-menopause but she don't like to remove her uterus, or she want to return her fertility, so this patient you need to confirm that there is no concomitant, and it's written clearly in the guideline. If this patient you want to let her for conservative measures, so you need to confirm again, and there is no concomitant cancer because there is 43 risk. So this patient you need to do transvaginal ultrasound to exclude if there is any ovarian cancer, CA125, MRI, and hysteroscopy.
Hysteroscopy for exclusion of a concomitant endometrial cancer. Yes.
And yes, and confirming the diagnosis, because she wanted to return her uterus. She don't want to remove. But if you wanted to remove, so remove, because you will send histopathology. So why you will do all this investigation? So just if she refuse.
If the endometrium thickness of postmenopausal woman is not reaching 4 millimeter and she has vaginal bleeding, we should make hysteroscopy for taking a biopsy also, or no need?
The cut value of the postmenopausal, I think in one talk article is more than 4. More than 4 you will take a biopsy. Less than 4, no. This is one from one talk articles, I remember. Yes.
Even she was postmenopausal and had vaginal bleeding.
Except if they change. But what I remember, it's more than 4 postmenopausal.
Doctor, for tamoxifen,
because it is written that 10% of postmenopausal woman has bleeding, it may be cancer. Like this?
Yes, 10% of the patient, but you will not do endometrial biopsy for all the patient, especially if the endometrial thickness 4 millimeter or less. More than 4 millimeter, more than this is means the endometrial atrophied. So why you will take biopsy? So you will not all patient will come to the clinic. You will do for her biopsy. You can't do. You will need to do the cut value more than 4. More than 4, you will take biopsy. Otherwise, you will not.
I ask because some books recommend hysteroscopic biopsy. I ask for this only.
Less than 4?
Yes.
Okay, just to post the question, we will see the question. What is the idea from the question? But the cut value more than 4, post-menopausal bleeding, because there is risk 10% of the patients will have cancer.
Okay,
no, but if it is
ma'am.
less than 4 and there is some polyp or something, then we can do hysteroscopy, no, ma'am.
We are talking about polyp, or this is different
no,
questions.
Postmenopausal bleeding.
Polyp, this is at least for more than 14 millimeter. You are talking about something more than 4, but she is talking about endometrial thickness less than 4. She didn't mention about polyp. Polyp, sure, you will need hysteroscopy to remove. And we got here one of the indication that if there is endometrial hyperplasia detected in polyp, it should be hysteroscopy to confirm.
Dr.
Yes,
Fatima,
ma'am.
cut off tamoxifen.
Assalamualaikum, Dr. Gada.
Yes.
Assalamualaikum, Dr. Gada.
Yes, Dr. Salma.
Can I ask one question, please?
Yes, Dr. Salma. How are you, Dr. Salma?
Fine, thank you. How are you?
You are preparing for part 3, correct? Or what? You return to part 3 again?
No,
You
part
return
3.
again?
No,
Okay.
part 3, why I like your lecture.
Nice, nice. It's very important for part 3, especially there is no exam. So you should refresh this excellent step.
Yeah.
Yes, Dr. Salma.
Yeah. You told that now that if it is endometrial thickness, if it is less than 4 millimeter, there no need for biopsy, endometrial biopsy. This is, good. This is correct. But if it is premenopausal, that means she's like she didn't reach menopausal. Okay, so then how much the endometrial thickness will be? Then you will do the endometrial biopsy if it's premenopausal.
I'm not sure from this point, but if you have one patient premenopausal with irregular bleeding in spite of medical treatment, first you will try medical treatment, and this patient, she has persistent interministerial bleeding, this patient should be for biopsy to confirm that there is no any endometrial hyperplasia or cancer. If you will do ultrasound and there is polyp in patient with premenopausal, I think in one talk articles they mentioned regarding the polyp, I think more than 14 millimeter, if I am correct. More than 14 millimeter, it will be a polyp.
No, I'm not asking about the polyp. I'm telling that if she has premenopausal, if it is premenopausal,
You want the cut? You wanted to ask about the cut value of endometrial thickness. This is correct.
Endometrial thickness for premenopausal. For premenopausal.
Yes. Okay. This is my answer. This is my answer, and I also I will confirm again. My answer that the patient with premenopausal, if you will do ultrasound until 14 millimeters, this is no problem. But more than 14 millimeters, this could be a polyp. More than 14 millimeters, this is called a polyp. I think I read this one in one talk article, maybe 2016, if I am not wrong. But if this patient, for example, her endometrial thickness 10, for example, her endometrial thickness 10, okay, and I give her medical treatment, she has interministerial bleeding, I give her medical treatment, and still she is persistent, she has persistent interministerial bleeding, in spite of medical treatment, and her endometrial thickness 10 or 8, I will do sample, because this is one of the indication of persistent interministerial bleeding in spite of medical treatment. This is indication of endometrial sampling to exclude underlying endometrial pathology. But cut value, there is a certain cut value for the perimenopausal, the point if it is polyp, and if it is polyp when more than 14 millimeter, but let me confirm the number, if I am not wrong about the value, more than 14 millimeter, it will be a polyp. So you need to do hysteroscopy and removing and send for histopathology.
So that means no bleeding. With treatment, she is okay. There is no bleeding. But if it is endometrial thickness less than 14 for premenopausal, so it is normal.
Yes, you will give her medical treatment according to the NICE guideline. You will give her medical treatment, and if it is failed, you need to take biopsy. Clearly, I can post this one from the NICE guideline. As I remember, failed treatment, medical treatment, interministerial bleeding, this patient for biopsy.
No, not failed. I'm asking that her with treatment, her bleeding is okay, but what do you recommend her premenopausal endometrial thickness? How much it will be, the cutoff point for premenopausal?
There is no any cut value. I didn't see any cut value except if you see the endometrial thickness higher than 14 millimeter, and this means that this patient she has bleeding. Otherwise, no.
So
I just
okay.
Ma'am, I have a question, ma'am.
Thank you, Dr. Salma. I can hear your voice.
Hello.
Yeah.
I want to ask the
Okay, thank you.
Ma'am, if there is
hello. We'll take only one question more. Then other questions post in the group, just one question more, but make it the question related to the topic. We are taking now about something not different. I want the questions regarding herpes. I want the questions regarding endometrial hyperplasia, because this is the today's session. So we need the questions regarding today's sessions. Other questions we can post in the group. Okay? What is
thank you. Thank you.
Last question. Thank you, Dr. Salma. Last question. Who will ask? Last question.
Ma'am, okay, when you told about term prom, term prom with recurrent HSV, recurrent herpes.
Yes.
So the answer was to expedite the delivery, right? So
yes.
If there is an option of expediting delivery and there is an option of expedite delivery plus give acyclovir, so will it be better to choose the option of giving acyclovir as well? Because we'll have to give recurrent with term prom if she is.
Yes, I will choose if the both with each others. I will choose both. Both mean expediting the delivery and acyclovir, oral acyclovir, because yes,
so
oral. Yes, she will. Yes, we just mentioned if she has recurrent, she will take again either from 36 weeks. Just now we mentioned if the patient she has herpes, she will take. Correct.
Okay. Thank you.
Can I ask one question?
Last question, please, Dr. Adila.
Yes. If
Dr.
the
Adila,
patient...
you are in London, Dr. Adila?
I am in Cambridge. Yeah.
Yes, because I saw all the emails last time, so I see frequent countries, France and London. I saw your name in London, so I'm surprising. I thinking that you are talking from Sudan.
Yes, I am in Cambridge, Dr. Agada. To ask about endometrial hyperplasia without atypia. If she decides to go for observation, what will be her follow-up?
Observation. There is no. It's not written clearly. They put that the treatment is better than observation. So if he, for example, putting you something, so you will follow the same like treatment. So every 6 months. But in the guidelines, they recommend the medical treatment because it will be more effective than observation. So if the patient refuses, I think this question will not come. But if come, you will choose the same every 6 months until two negative biopsy.
Okay.
Other questions post in the group. You will not finish questions. Other questions in the group. I will try to post some important records in the group by voice, just to follow it. Just small records every day. I will try to do some important questions could appear in the exam. I think there is hope that you can pass the exam. Don't worry regarding the pass or fail. Just trust yourself. You will pass. If you will try, sure you will pass. I failed before frequent times, no problem. Just keep in the main track for the exam. You will pass. Don't lose hope at all. Just fight until the last second in the exam. Follow the group because still there is some records I will post. It will be very important. I will post inshallah in recall group. Thank you for all of you. See you inshallah in the group. Goodbye.
Dr. Agada, sorry, I want to ask, which group you mean? Telegram group or Facebook group?
I will post in the Telegram because it's difficult to post voice records in the Facebook. I will try, if possible, I will post also in Ghada Badran group, Facebook, or call group in the Telegram. inshallah.
Okay, thank you, Dr. Ghada.
Thank you, Dr. Nerveen. Goodbye.
मम्मा मेरी टीचर ने वेल करो बेटा मुझे